In this video, premature ejaculation. What is it? What are the causes and treatment options? We discuss this with Dr. Jeffrey Rutherbush and Gil T. Welcome to this channel. If you want to learn more about the most cutting-edge science-based information in the world of hormone optimization, please subscribe and hit that notification bell. Welcome Gil, welcome Jeffrey. First question for the both of you. What is premature ejaculation? Maybe Dr. Jeffrey Rutherbush, you start. What are the symptoms?
Yeah, I wish I had died every time I saw that. But you know, the real problem with PE is hard to define. And depending on the definition is how you determine the prevalence. And some books, and again, I've got books on sexual medicine and contemporary ED treatment and the book on testosterone and all these guidelines here. But the prevalence has been determined to be upwards of almost 40%. So it actually is the most common erectile dysfunction we see in men. And there are two types, usually lifelong, which, you know, begins when a man first starts sexual encounters. I don't want to say congenital, we don't start having sex in birth, but usually it's lifelong. Like I said, it starts when the man first starts having sexual intercourse, or it's acquired. He didn't have that, and all of a sudden he acquired it. And it depends on how you define the term. Again, if you look at intromission, fancy word for penetration into the vagina, you define it as a beginning right then, and then going to ejaculate. Some people will tell me when I ask them, because they'll come and see me, and they say, "Doc, I got PE." I said, "Well, how do you define it?" Well, I can't last as long as my wife, or I'm usually having orgasm within 2 or 3 minutes. I said, by definition, you don't fall into the category of PE, because the books all say anything under a minute, now you qualify for that disorder. So over the time, I kind of developed my own definition of what it is. It's very simple. It's just basically that you're not able to delay your ejaculation until you achieve sexual satisfaction. And that's a big word, meaning it's a simple definition. But some guys are happy with a minute or two, just because they're happy and she's happy. Some guys want to go 5, 10, 15 minutes. And to them, anything inside of that time is not a successful sexual. So I've adopted a different, definition for it. I want to adopt the most wide definition so I can help the most guys. Some doctors, these patients come in, they say, "Man, I got PE, but doctor said that I lasted for, a minute and a half. I don't have PE, so you're not going to treat me." I said, "Well, are you happy with your lovemaking session?" And they say, "No." Is your wife or lover happy with your lovemaking session? He says, "No, she's not." I said, "You have PE by definition." Okay, no, there are some guys, I tell them you can't have sex for 2 or 3 hours straight and then have an orgasm and then think that's not long enough. Something just common sense. So again, I like to have the most wide definition of PE so I can help the greatest number of people. It's very hard to define. So I use that wide definition. So again, I feel that I'm able to offer therapy for the condition. Now, I'm older. When I was younger, my dad worked for a drug company called Ciba. And they had a topical ointment called Nupercanol. It was a topical anesthetic. So my dad, in all his wisdom, decided to take some of the samples of Nupercanol, take it out of the sample vials, tubes, package it in little canisters, and take it out to sell to in the streets as what he called was Prolong. This is back in the 60s. So it was a topical anesthetic that numbed the penis so you had less sensation, so you go along. The problem with that is that you have contamination of the vaginal mucosa. And so the woman would also lose some of her sensation, and she wouldn't enjoy it so much. Okay? It's been around forever. Now, we've all heard of Hims and, oh, what's the other company that you can dial? They have these, these sexual things you can call, get men's products. Their solution for PE is a simple 4% topical cream that has benzocaine in it. So it's been around a long time. In the old days, we just put a topical numbing medicine on the penis. There's all kinds of things you can do, like pinch release method, try to learn how to handle it. But there's a lot of psychology involved. I think Gil knows it. Most of my younger guys that had lifelong PE had a lot of anxiety or some type of trauma in their life, sexual trauma. So you do have to do a careful history to find out what the best approach is to this, to solving this man's PE. We in the men's clinic that I used to, there are some medicinal, some pharmacological approaches. We had a company that would prepare for us now, I may be getting ahead of the ball game here. I'm going to some treatments.
Mm-hmm.
But again, it is, in my opinion, the most difficult treatment to overcome. I mean, I have a lot of guys that I was not able to extend their sexual intercourse to their liking. So I would refer to a medicine we called Restenza. It's just a medicine that was compounded for us and had 3 active ingredients in it. It has a dextromethorphan, which, if you know, it's just an active ingredient in cough syrup. And it had tramadol, and these both work by increasing serotonin levels. And it had a little, I think, Viagra, sildenafil. Great medicine. Problem with it is a lot of side effects. A lot of my guys had nausea. The number one side effect was nauseous. Now, as an orthomolecular physician, I don't really like giving guys medicines that have so many bad side effects. And a lot of their absolute or relative contraindications to giving Restenza were the same conditions guys came in with. So, I don't know. It was very difficult for me to treat. But Restenza was nice to use. It worked in a small percentage of people. If I couldn't cure their PE, I'll just say, we need to go on a bi-mix or a tri-mix to just give you up longer. So if you do have a premature ejaculation, well, lovemaking is not over with it. You'll stay erect, so you can continue on, satisfy yourself again, and definitely satisfy your partner. So I would fall back on the intracorporeal pharmacology if the topical anesthetics or the pharmacologic oral meds didn't work. Mm-hmm. So Gil, tell me about what your clinic does for PE.
So I want to touch on one thing you said, Jeff, and as physicians, you'll both appreciate this, but I think the masses don't quite understand the difference between defining conditions in a clinical versus a subclinical method. And, clinically, some guys, like Jeff mentioned, would not be considered PE candidates, and they may be discounted and written off as such. But again, this is more of a subjective condition. As he said, what is satisfactory to you? Now, within reason, obviously, somebody who comes in, egotistical and says, well, I need to last 3 hours, anything subpar is insufficient. Let's be real here. 3 minutes is not clinical premature ejaculation, but granted, it does pose issues and it does ruin relationships over time. And there is no reason someone should be turned away just because they, quote unquote, fall into a category. And it's no different than hormones. We all know very well how guys are turned away because they fall out of a clinical range. So when you're assessing someone subjectively and they tell you this is hindering the quality of my life and we have the opportunity to help them, now comes the part where I feel it's most important. And this is why oftentimes when we get guys on a form saying, I have this issue, what should I do? Well, they're describing a symptom, but they are bypassing a very crucial part that comes before diagnosis, and that is the assessment. Without the assessment that encompasses so much more data than just defining symptoms, it is literally impossible for anyone to recommend a plan of intervention. So part of this assessment, much like Jeff mentioned earlier, is to define, is this something that has been chronic? And if so, was it a physiological condition or was it a psychological condition that started earlier on? Or is this something that is related to a current condition that's going on, and did this just start in the last year or two? Another issue is we want to rule out performance anxiety. Some guys have been trained from early on that, masturbation is a bad thing. Watching porn is a bad thing. And, if you get caught doing it back when you're a teenager, someone walks in on you, you're in trouble. And they were literally training their body to respond in a rapid way to this stimulus. And now they've carried this on all these years. The second one is guys who develop a form of ED. And let me just clarify, erectile dysfunction comes in many different degrees. It is not just impotence. Guys think, well, if I can get it up, I don't have erectile dysfunction. The quality of erection, the duration of erections, all encompasses, whether or not someone has a form of erectile dysfunction. If your firmness is not where it used to be, if you've experienced any levels of atrophy, if your nocturnal erections have diminished, if your duration has diminished. These are all forms of ED that a lot of guys go undiagnosed until it becomes a bigger problem. And part of the solution is obviously attempting some angiogenesis techniques over time, which I know Jeff is very familiar with because I think we follow some of the same protocols on that. But a lot of times you have to first diagnose, is this a psychological issue or a physiological one? And once you have that under control, you can plan an attack of how to intervene and how to correct it. And then the evaluation process, you're going to determine if you've done that successfully. So once we start going into this treatment options, I think both he and I can touch a little bit more about various different methods.
Yeah,
Okay.
I agree 100%. Sorry, Stephen, but you're right. The lifelong guys with the, they're the ones that had the indwelling. I mean, the problems psychiatrically, they're psychogenic. There's a lot of problems psychogenic. And those are the guys that were toughest to, in my opinion, to treat. A guy who came in who did not have the problem and acquired it. One of the things I always found was that either they went through a divorce and hadn't had sex in a while, then it finally hooked up. There's a lot of anxiety getting with a new person after being with their wife for decades. That was causing some problems. But those are the easiest guys for me to treat because I tell these guys, listen, you're experiencing what I call beautiful strange. Anytime you have something that's new and improved, a new model of a woman, so to speak, you're going to have more, I guess, anticipatory feelings, and you might reach orgasm a little sooner. And by your definition of how you could control it with your wife for decades, now it's not satisfying you so much. And again, a lot of guys would come in and they weren't happy with their duration, but the wives really were. They wasn't there. Many of them weren't complaining. Now, there were some people, women that came in and would say, yes, it's coming, he's orgasming way too soon for my delight. But again, what Gil mentioned, yes, when we took a history and physical, the things we do is say, listen, a subset of ED is indeed PE. And many times they go together in the same individual. And you have delayed ejaculation, also a subset, or anorgasmia. A person can't climax at all. That is also a subset. But yeah, I see it. I see it a lot. Probably treated, I don't know, probably a couple thousand guys with it. But I always found it was the most difficult for me to treat satisfactorily. But I had some things to fall back on, and Gil knows, just we'll buy a mix and try and mix them, so the person can then not worry about the orgasm. I mean, he can work on his, I guess, mind as far as, listen, if Gil and I both know, if a guy's worried about performance and worried about having the orgasm, he may lose the erection. And then he's worried about other things that exacerbate the PE. I tell my guys, listen, failure breeds failure, but success will breed success.
Yeah, it's almost like, you bring your thoughts into reality. So an anticipatory response to a fear or anxiety is going to lead to a negative outcome. And part of the assessment that we like to utilize in diagnosing the difference between a psychological issue or physiological one is a very simple question, which oftentimes when you ask and then explain why you're asking, all of a sudden a light bulb goes off and you say to the guy, look, when you're on your own, do you run into the same exact issues, the same lack of quality in erectile function, the same PE or anorgasmia or any of these issues that you run into with a partner? And furthermore, again, some guys come in and confide in the fact that they have more than one partner. The question is there consistency between several partners? And if the answer is no to any of these questions, then you have to understand that there is some anxiety involved here, because if you have a physical issue, if I got a broken leg, I can't walk in Rome and I can't walk in Paris and I can't walk in London and I can't walk in New York. But if I think my leg hurts because of a stimulus, but then it doesn't hurt when that stimulus goes away, then, the problem is really here. So when this guy says, no, I have no issues, no ED, no PE when I am masturbating, but all of a sudden, a partner walks into the room and it's like, a deer in headlights. Well, performance anxiety is something we need to treat a little bit differently than a physical issue. And it's a relatively easy assessment when the answer is as clear as that. If the answer is not as clear as that, there's, further assessments that need to be done. What's your take, Jeff?
Well, I agree that the biggest issue, and maybe I didn't cover it clearly enough like you did, Gil, but the history is so important to figure out your initial approach to the patient. The history is like anything in medicine, Stephen. Don't we know this? The history, the history, the history. And, some guys, problem with taking guys' history, they're sometimes erratic, sometimes they're inconsistent, sometimes they don't quite tell you the whole story. But you have to evoke it, like pulling teeth to get a better history. And sometimes a guy will come into me several times before he told me the real story.
Okay, so you touched on the definition for sure, and anything you wanted to add about the causes, possible causes? Gil talked about porn addiction and the other things that might trigger premature ejaculation.
Well, I mean, if you study it, like in that Journal of Sexual Medicine here, there's a lot of causes. That's why it's hard to really get to the root cause. You got to ferret through all the stuff to get down to the root cause. Trauma, abuse, anxiety, even this hormonal disruptions, thyroid dysfunction can cause it. But I just find that the biggest issue in my clinical experience is usually psychogenic issues. But they're the most difficult to overcome.
We have to remember, Steve, that orgasms are not controlled by the body as a physical response. They're controlled by the brain. And the ability to control and fully gauge the timing is something that takes practice, and it's something that is trained, and it is something that can generally be retrained. Sensitivity is nothing more than a physical stimulus. It is still your neurons that have to transmit that response, and how you perceive that stimulus. There are people that are able to meditate, and kind of like put aside pain. It doesn't mean the stimulus is any different. My biggest issue with, I know nowadays, Jeff touched on what his dad used to do back in the 60s. Nowadays, I've seen guys use lidocaine or BLT cream. locally to try to numb. To me, to give you an analogy, that's almost like buying a luxury car and saying, I'm not going to drive it because I don't want to put miles on it. It's counterproductive to the point of why you got this in the first place. You're trying to have a sexual encounter for pleasure, presumably, and by numbing that pleasure, that sense, for the sake of delaying it, you are essentially writing yourself off for either your ego or your partner, but you're now numbing yourself, right? And then there's also the risk of transference, which Jeff touched on. So to me, that is more of putting a Band-Aid on an issue. The other ways that I think people generally find success, and I can give you 3 solutions that I've seen work very well. And we can go from the, I guess, least invasive or least side effect one all the way up. And now we're assuming that we ruled out a hormonal issue, okay, because dopamine and prolactin could play a part in that as well. But once you've ruled out the hormonal issue and assuming hormones are balanced, if someone's still experiencing this, I have found that PDE5 inhibitors dosed low daily do tend to prolong orgasm. So the ability to alleviate a 2-3 minute PE issue and turn it into a 10 or 15 minute issue in most guys is generally handled fairly well with a low daily dose of tadalafil, which has a decent half-life and is able to be stacked that way. And it's funny because I was having a conversation with Dr. Grant about this the other day, and we were brainstorming about how the mechanism of this actually works, because it's essentially a vasodilator. And I don't think it's quite understood, the pathway of how these medications can actually, because that's not what they're designed for, right? They were initially designed for hypertension, and then they found that, hey, these have a pretty good effect on erectile function and whatnot, but we do know that they have other benefits associated with them. And PE is not one of those indications on this class of medications, but then we have found it to work fairly well, and they're fairly side effect friendly at low dose, especially tadalafil. I know sildenafil tends to have slightly more side effects, but that is probably the path of least resistance. And most guys who are coming in for hormonal or sexual treatments are probably not going to be too resistant to trying that type of a drug. The second one, I know that Jeff touched on it earlier, would be the local vasodilators, and those are directly the bimix, trimix, quadmix, and those generally contain 2 or 3 different drugs in them. It's a firmness medication and a duration medication, which are essentially dosed according to the underlying issues that a man can have, from hypertension to diabetes, to fibrosis and various other issues. They tend to work very well in most patients. I would say over 90% of patients do respond very well in the first 10 minutes with that medication. You alleviate all of the PDE5 side effects because they're not systemic. They are localized, and they get the job done. And then when you have a psychological issue like performance anxiety and you administer one of these medications, as he pointed out earlier, what this does is it doesn't necessarily negate the PE, but it allows them to perform. And when someone builds up enough confidence in his ability to perform over the course of several months, oftentimes you'll notice that the anxiety that caused the PE in the first place begins to diminish and normalize. And then at that point, if you didn't really need that medication from the beginning, you can start to titrate off and go back to a normal lifestyle. So that is definitely a nice approach. The last one, which I personally dislike, it is, in my book, absolutely the last resort. Unfortunately, a lot of primaries or maybe even psychotherapists are going to use this as the first approach, is, SSRIs, okay, selective serotonin reuptake inhibitors. I don't like to mess with neurotransmitters. I don't like to block serotonin channels and whatnot to try to, but these have proven to prolong orgasm. In fact, guys who are on antidepressants who don't have PE often experience anorgasmia because it has the opposite effect. So when you have PE and you're kind of inhibiting the ability to orgasm, oftentimes all you're going to do for that guy is delay it. So a very low dose SSRI as an absolute last resort, if it really becomes an issue, is something that has also been shown to work. Personally, I'm not a big fan, but like I said, I would exhaust all options prior to going that route.
Yeah, I don't know about you, Stephen, but what I learned about SSRIs is that, in clinically, my experience is that, yeah, they tend to work sometimes for PE, but about 40% of my guys who came in with PE only went out, now they got ED. Because one of the side effects of an SSRI is ED. So now I've added, I got a guy had PE, took care of his PE, but now he's got ED. So I don't like, I agree with Gil. As an orthomolecular physician, I do not like creating neurotransmitter imbalances in the body. Because guess what? An SSRI will create a buildup of serotonin at the synaptic cleft,
In the
and that
synapse.
will create a neuroendocrine or hormonal disruption. It does. It doesn't solve one like the psychiatrist will tell you it does. It doesn't. It creates one. So that's the least of my the meds I like to use is SSRI. But yeah, there are a lot of textbooks and doctors that think it's first line. You know, I think Paxil has the best profile for men with PE, but again, I don't like using them. Last resort. And oh, by the way, when I went to Atlanta, when I first got hired on by that company, Gil, they sent me to Atlanta to take a course, and a week-long course in sexology or men's health. But I didn't know this, but they're Target, Target. Target has a product called Promescent, Promescent, Promescent. You get it at Target. It's 2% lidocaine spray, and it absorbs so quickly in the glands that you only have to wait 10 minutes, which is not too much time. That way
It's
you don't
just a
have
numbing
cross.
effect.
Exactly. But I didn't know that Target had this, in their pharmacy department.
You can go up to 5% in lidocaine concentration in a topical without the need for a prescription. As we know, the lidocaine creams used in clinical environments are a lot stronger. I think 25% is the norm for the one we use for numbing, prior to, injections and P-shots and stuff like that. But you can go up to 5% in a topical without a prescription. And Stephen, as a dermatologist, I'm sure you can concur, there's a lot of dermatological products out there that are essentially no different than the over-the-counter, except for the strength of the concentration.
Yeah,
Right.
exactly.
Various bleaches and ointments for for acne and stuff like that. The only difference is the concentration.
The concentration, exactly. Yeah. We have these
Yeah.
lidocaine creams. We use up till 5% here as well, over the counter, that people use for Botox injections when they come to me, for example.
Yeah. I think hydroquinone is a pretty popular
thing.
one for dark spots, right? And
Same thing.
that's a prescription, strong dose, and then you can get the over-the-counter bleachers or lighteners that that really are not that effective unless you use them very long term with high frequency. So again, I mean that you mentioned before the company Hims, which has gained a lot of traction through marketing. Now I've seen ads where they sell PE wipes. Now those wipes are essentially like transdermal applicants
Right.
that you wipe on, and they're supposed to create a numbing effect.
Yeah, it's 4% benzocaine. Yes.
I don't like that approach. I really don't. You're telling someone if we take away the feeling, you're not going to orgasm. Well, great. If you take away the feeling, what's the point, right?
And I tell you what, those cells.
Of course it does. Everything. Look at Nugenics for testosterone, for God's sake.
Yeah.
Look at GNC, billions of dollars in sales in Nugenics, a damn herbal pill that is supposed to make a dent in your testosterone levels. Now, we don't even have to go there, but the three of us know a thing or two about that. And I mean, it just irks me every time I walk by a vitamin store and I see that stuff on the shelf.
Yeah, but Frank Thomas uses it. Frank Thomas uses Nugenics. It must work,
Hey, you want to write me a nice check? I may consider using it too.
Okay, guys. Let's wrap this up. Anything more you wanted to add, Gil or Jeffrey, for premature ejaculation?
The only thing I would add, and this is more of a social advice rather than medical, I would tell guys to not be afraid to seek help. Men have this egotistical approach. See, women hit menopause and they go crying for help, rightfully so, and I commend them for doing so. It's spoken about quite often. Men go through andropause, and because it's a gradual drop and it is not one that is felt as quickly as menopause is, combined with the fact that they have to uphold this macho image, they don't ask for help. This includes hormone, this includes erectile dysfunction. Heck, we get guys walking into a clinic telling us, I haven't had an erection in 10 years. I lost 3 relationships. And it took them 10 years to ask for help. Guys got to wake up. You're human. You're made of flesh and tissue. You break like everyone else. No one is going to point fingers and laugh at you. People are there to help you. Find a competent provider who understands what's going on. get in there, ask for help, fix yourself, enjoy the quality of your life. Life is short. It is way too short to waste a decade suffering when you don't need to. All right, there's enough chronic diseases out there that we don't have answers for. God forbid you get one of those, there's nothing we could do. You have something that is extremely curable and treatable, and there's no reason for you to suffer. So get over your ego, ask for help, and get it fixed. That's it.
And Gil, there are actually bona fide studies that indicate that men who have regular sex live longer than men that
100%.
Yeah.
100%. I mean, prostate health is just the beginning. You know, psychological and emotional health, you know, neurotransmitter effects of a healthy sexual lifestyle. All of these things, I mean, we know this. It reduces blood pressure, reduces risk of cancer. We can go on and on. But at the end of the day, they don't have to write it off just because of a hiccup in the road. You don't drive down the highway and see a pothole and make a U-turn. You know, you find a way to go around it. So.
Great advice. Thanks.